Hi, my name is Clinical Pharmacist and you're watching a video on the management of esophorias. Okay, now we'll go systematically through the various options we have in managing a patient with an esophoria. Let's start off with the correction of refractive error, so prescribing glasses. We would do this according to the principles for managing a patient with an ESO deviation. So in relation to hypermetropia, we have the option of fully correcting or undercorrecting the patient. And my recommendation is that because you have a patient who is controlling a deviation at times, so they're controlling this esophoria, but then decompensating and losing control at other times, I suggest you give the patient the least amount of plus that gives that patient control so that they can continue exercising their relative fusion divergences. With myopia, you want to undercorrect this to keep the patient as relaxed as possible in terms of accommodation. And with astigmatism, you would fully correct this if it's significant in amount. Moving on to prisms, as with the exophoria, you only want to prescribe prisms if you've been unsuccessful with other treatments, in particular with glasses or orthoptics. So if they fail, then you can look at prisms. And for prisms, we will give the patient a base out prism to bring that image onto the fovea. Now, if you have a patient who has a significant decompensation of their esophoria and they're losing control most of the time, so they're manifest much of the time, then you could actually consider giving base out prisms early on, which will bring the images fovea to fovea and then prescribe the orthoptic exercises on top of that. And if you do this and give the base out prisms early on, then you would wean the patient off as the binocular functions of that patient improve. So the outcome would be that you're not using prisms as a long-term solution. Moving on to orthoptics, what we want to achieve here is comfortable BSV. And to do this, what we're going to need to do is improve the negative fusional divergence and improve negative relative fusional divergence, so that divergence range. And we need to get that patient to be accommodating ahead of their vergent system, or converging less than the amount of accommodation that they're doing. In relation to the exercises we would prescribe, below I've given you exercises that are considered divergence exercises, and clearly this is what we want in a patient with an ESO deviation. We want to diverge the eyes out. However, some of these exercises, framing, hole in the hand and slit Remy, don't really have an impact on negative fusional divergence or negative relative fusional divergences. They are mostly relaxing exercises. So they're the type of exercises that are good for patients who've had, for instance, convergence exercises and you want to relax their vergent system post-treatment. So if you want to target fusional divergence and relative fusional divergences, the best options here are basing, prism, stereograms or bar reading. With stereograms, remember now we'll be in the stare-through position, so the patient will have to have a target behind the stereogram so that their vergence is behind their accommodation. So they're doing less convergence than accommodation. And remember, they need to see these caps clearly, so they need to accommodate at this distance whilst their vergent system is here at this distance. And finally, in relation to more invasive procedures, Botox and surgery, these are types of treatments that we give in patients who've been unsuccessful with other forms of treatment, such as orthoptics and glasses. So with Botox, we would inject the medial rectus in an attempt to give the patient BSV. With surgery, generally the patient has decompensated significantly and has quite a frequent esotropia, in which case you then might consider actually operating on the deviation. In terms of what type of treatment, go by the near distance disparity. So you'll see here I've listed that if you've got the near angle larger, go for the 2 medial recti. If it's the distance that's larger, you go for the 2 lateral recti. And if it's non-specific or basic, then you would do unilateral surgery or assess and resect procedure. That's based obviously on the principles that we've discussed earlier. You may see in your notes or in your reading that other types of surgery are suggested, but for now I just want you to manage the patients according to the principle, and then as you move on to placements, you'll see the variations in the way in which surgeons operate on deviations. Okay, that brings us to the conclusion of this video. Thank you for watching.